Hello and welcome back, everyone. We are at the MNLA Scientific Sessions in Miami. It's the last day of May 2025. Thanks for joining us for Lipid Insights. We're talking to Katherine Cheeley and Michael Wilkinson today about a paper that's just dropping at the Journal of Clinical Lipidology from the National Lipid Association called Multidisciplinary Teams in Clinical Lipidology and Cardiometabolic Care, a National Lipid Association expert clinical review. Welcome to both of you.
Thanks for having us.
Thank you, great to be here.
Before we start, I am going to ask each of you to introduce yourselves, tell us where you're from, tell us what you do for a living, and tell us why you're interested in multidisciplinary care.
I'll go first.
Go ahead.
So I'm Katherine, like you said. I'm from Atlanta, Georgia. I work at Grady Health System. I'm the executive director of Ambulatory Pharmacy, so over all of the ambulatory space, be it our clinical program or our retail locations. But my first life and my first love has always been lipids, and making sure that I had the opportunity to be a clinical pharmacist in a lipid clinic, which completely changed the trajectory of my career, being a part of this amazing organization and having that collegialness with physicians or dietitians makes our patients' care so much better. We had a point in our lipid clinic where we didn't have all of these resources, and so I think making sure that folks know that this is really the best way that it should be done. And then what we're really proud of in the paper, which we'll get to later, is how to access that when your health system may not have it.
So I'm Michael Wilkinson. I'm a cardiologist and lipid specialist at UC San Diego. I direct the lipid clinic there, and I'm also involved in a lot of research, clinical, translational research. This paper was very important to me. It has so much to do with my everyday practice in clinical cardiology and prevention and lipids. And I practice as a part of a multidisciplinary team, which is so critical to, like MK is saying, optimizing care for our patients. And I really enjoyed this opportunity to really dig into that, define some of the roles for these really critical members of this team.
Great, thank you both. I like you, I'm a clinician. I practice in internal medicine and primary care and in a clinical lipid specialty practice. And I think all of us who've trained as clinicians first started training as part of a team, right? As you're coming up, as you're going through training programs, you're always part of a team. There's a hierarchy, you're learning from other people, you're teaching other people, you're interacting side by side with people who are training at different levels and with different disciplines. However, I think a lot of us finish our training and are launched out, especially if you go into private practice. And the term private practice actually almost has built in this sort of very narrow private care. And in reality, you really do feel like you're on an island and you have to be completely self-sufficient in your care. That's changing a bit. I think that the model, I'm older than both of you, I think the model of care that I grew up with was very much self-sufficiency, independent practice by the clinician, in many cases the physician, and that over the last generation, this has changed in practice. Systems are really how we're starting to provide care. Not starting to provide. We are definitely providing care in systems,
right.
And systems have implicit this whole team-based practice. And so, MK, is that why you wrote this? Was to sort of give us a sense of how clinicians should be practicing and working within the team?
Absolutely. So I think what's really important when you're thinking about the system is that each person on the team has an expertise. I did not go to school to diagnose. I'm going to leave that to you guys. But I went to school to make sure that these are the right drugs and patients can be successful on them. And you guys didn't go to school for that. So you do what you do great. You assess, you treat, you diagnose, but let me handle the part that is frustrating to you and you didn't necessarily go to school to be an expert at, of access or adherence or, again, picking the right meds because of drug interactions. And when we can do that, we can be more efficient. And when we can be more efficient, we can see more patients. And when we can see more patients, we can make a bigger difference across the board in the continuum of care that we have. And I think there's been a lot of other societies and a lot of other associations who talk about this and like put it in other papers in other ways. But we really wanted to call it out in a paper saying, this is what the team looks like. This is how the team can be successful. And so making sure that it was its own standalone document and not buried in something else, I think was really important to us. And honestly, we're really proud of it. We are excited about how it looks.
Yeah, so I think one of the things that we really wanted to define were all of those potential members of this multidisciplinary team, because I think, like you're highlighting, Dan, this may look a little bit different in different practice settings. And I think, part of it is bringing to our attention all those people who can help to make these things happen, no matter where you are. And, maybe if you aren't fortunate enough to work with a pharmacist, there's going to be somebody else in your team who has or can develop that expertise to, help patients with access to therapies and help manage side effects and field calls from patients. That might be your nurse. And that was something very important to me, was to highlight the role of nurses in the care that we provide.
Absolutely.
In addition to other members of the team, as we discussed throughout the paper.
Yep. Mary Kay, I really like the way you highlighted what the NLA does, because it was actually my introduction to the NLA was former president of the NLA, Joyce Ross, grabbing me by the ear and saying, hey, you're coming to the NLA.
I can see that happening,
and,
actually.
Joyce Ross, nurse practitioner. And she said, you need to be part of the NLA, and here you're going to start, you're going to do this, and you're going to do that. And so, I knew right off the bat, this was not just an organization for physicians. It didn't mean as much to me at the time as it does now in retrospect, when I realize all the people I collaborate with at the NLA who are non-physicians, and how I've learned about different perspectives of care, different levels of expertise that can make us all so much better, and just the breadth of knowledge and information that you get instead of just rubbing elbows with physicians and like-minded people who have the same types of training. So I love that heterogeneity of thought that's made us all better.
I would just like to take that opportunity to thank our co-authors who represent that diversity of expertise within the NLA, which is so special.
All right, so tell us who the authors were.
We had Carol Kirkpatrick, who is a registered dietitian nutritionist. We had Emily Brown, who's a genetic counselor, Dave Dixon, who's another clinical pharmacist, Heather Gunter, who is a clinical nurse, and Diane Osborne, who's a nurse practitioner.
And to have this group of individuals with different background, expertise, but all practicing within some form of a multidisciplinary team and lending their insights was, I think, part of what makes this such an exciting paper.
Yeah, you think that made just the paper writing. So we were talking about the clinical care, but the paper writing, you're right, I didn't even think about that as you're writing the paper, different disciplines actually go about their writing and their scholarly work maybe in a different way, and having those different perspectives just for putting ink to paper.
Well, that and reviewing each other's work was really cool because it was interesting to see, oh, they talk about that. I should go find that in my literature and talk about that too. And it made it such a better, more robust document, I think.
Yeah, I've had the pleasure to work with some of those authors on other papers, and same thing. I can't wait to share what I've written with Carol Kirkpatrick, because I know she's going to find all the things that I could have done better and make me a better writer along the way. And so she's an incredible.
Yes.
All the writers that you worked with were incredible.
Absolutely.
So big team, and I tried to highlight how some clinicians maybe work in very small practices where they don't have a team around them other than the support staff at the front desk who makes the calls and gets people scheduled and signed out and gets the care paid for,
Yes.
and then maybe the assistant in the back room, and then the clinician. And so it can be a very small group at times. And then I think all of us work in academic centers where the group can be enormous. In fact, there can be members of the team who you've never met face to face,
Right.
but you interact with, electronically or as systemically. Let's start with that group, because I find sometimes I worry that sometimes the team can be too big. Is that a thing? Is that a real worry, or should I just not worry about that?
I don't know that I would worry about it unless they're not getting along, and then maybe
Right.
you worry about it a little bit. But I think that's actually one thing that you did a great job writing about in your section is it's not just one physician, it's multiple physicians and multiple disciplines that make up this team. And same, it's not just one pharmacist, it's a community pharmacist, it's a clinical pharmacist, it's a specialty pharmacist. And that's some of the barriers that we talk about in the paper as well. But yes, I think in an academic setting, you oftentimes have really great resources. But no, I wouldn't worry about a big team.
Okay. Well, what I guess what I was getting at is sometimes you have multiple members of the team that actually have different perspectives that can contradict each other.
That is confusing for the patient.
Yeah.
For sure.
Yeah. So do you have some strategy that could help unify this? Maybe, Michael, that's more for you. Since I think you pointed out in the paper that it's often that the physician is the team leader.
Yes.
And it doesn't necessarily have to be that way. Maybe we can get to that. But Michael, as the physician, do you have a way to sort of smooth that over to make sure the patient gets a single message?
Yeah, I think that's an important point, because whenever we're working in a team, we want to deliver a consistent message to patients. I did briefly want to say that one of the things I am proud of about this paper is that we acknowledge that we don't have to be strict about some of these definitions. Who's the team leader? It's the person with the experience, the expertise to lead the team, and that may look a little bit different across different health settings. But I think, as MK alluded to, when we're working together, when we prioritize good communication and respect, and I think part of that, purpose of this paper is so that we all learn a little bit more about the members of the team, what we can all bring to the table, and get people like physicians who may be, leading teams or in charge of a practice, thinking about the value that these other experts can add.
I'll say I noticed that difference of opinions comes in when sometimes you're not having that conversation with the other provider and you're just documenting things. Or, and again, one of the barriers that we talk about is the lack of consistent health records in our country. And that can oftentimes lead to this, what is seeming as discord, but not really. It's just misunderstanding. Or again, the patient's relaying back to Mike something that Mary Katherine said, but Mary Katherine's on a different health record than Mike is. And so it's through that they get confused.
Yeah.
And so one of the things that we call for in the paper is making sure that, again, you keep the patient at the center and you make sure that they are the one that has access to all of these different things, but it's important that we all can talk together too.
Yeah, I think that's a really good point. We've become so spoiled because if you're lucky enough to see somebody where all their care is in one health system,
Right.
you can see everything. You can easily communicate with internal communication, and you actually get responses back very quickly, and it's a lot easier. But we still have patients who where they get their care from other health systems.
Right.
And some are partially integrated, and some are not integrated at all. And I think we all, Mike, you probably have the same experience, and where you have these situations, you're seeing a patient, and you don't have a cell phone number to call to check in with that other clinician. You don't have an email address. You're going to send them a letter by U.S. Postal Service in 2025, and it reminds us of what it was like practicing 10 years ago.
Yeah. Yeah.
So this is a changing landscape. So
Yes.
hopefully those barriers are gonna come down
That's
a
what I
lot
was gonna say.
quicker.
Hopefully it gets easier and easier to communicate, because I think that is so critical.
Yeah. So then, all right. So that's the perspective from these big health systems, large academic systems with a single EMR and easier communication, so we can smooth that communication over pretty well there. Sometimes we have to pick up a phone and call someone. Oh my God, yes. If you can't see, Mary Katherine just fainted. We're gonna have to pick her up off the ground. Yes, pick up a phone and call. And it's a great way to communicate, especially when you want to emphasize a point.
Absolutely.
All right.
Yes.
But then you go back into a lot of our listeners and a lot of our members actually work in smaller silos, and they work in primary care, and maybe they are in that office that has, 2 support people or few support people. They're going to need ways to access these other members of the team, and we're going to get into who those members are. But how are they? That's an issue, right? Getting access to those members of the team. So actually, let's specifically ask you, Mary Katherine. You're in primary care.
Okay.
You need help with some pharmacologic management of a patient, and you think to yourself, "Man, I really wish I had access to a pharmacist." What now?
Pick up the phone.
What?
I know. Gasp. Pick up the phone, and you can get a community pharmacist on the phone. They actually, now, there are some that are a little more difficult to get to with the phone tree, but there are certainly very well-educated, well-meaning, amazing pharmacists, and they may have access to other drug resources that you may not. If you're talking about specialty drugs, so primary care is one thing, please talk to your community pharmacist. I would say in my practice, I don't have to do this in my practice, but if that were my practice and I were a provider in that, I would find my local independent pharmacy because those are going to be, number one, easier to get to. They're going to be a little bit more patient-centric and not so numbers-driven, so I'll have a little more time to chat with you or look things up. But specialty pharmacies are a huge win for any kind of specialty drug, be it in lipids, be it in something else. And the level of care is different between those than it is at your community pharmacy. So they have built-in accreditation standards that say you have to clinically educate patients, you have to track them for adherence, you have to do quality of life measures with these patients on a regular basis.
Sorry, that's for specialty drugs?
It is, yes.
Oh, interesting.
Yeah.
I did not know that.
You're welcome.
You're the best. It's funny because I think that it's less that I have questions about the medicine as much as how do I get my patient on this medicine? And I live in a very privileged environment where I practice, where I literally, ready for this? I write the prescription, I send it to our pharmacy. 1, 2, 3, magic happens, and my patient gets the drug, and I never ask how.
Thank your local friendly neighborhood pharmacist for that, or pharmacy team for that. Yeah, I think that is where the access piece is probably the most challenging and frustrating for providers. And that is where, like you mentioned, Mike, if you don't have a pharmacist, then you need to invest in training up another clinician that can help you with that. I'm pretty sure Heather is that clinician in your office. She's wonderful from what you say. She's wonderful to work with.
Who is this Heather she's talking about?
She's our clinical nurse on the paper.
Yeah.
And she has been one of the directors, nurse directors of our outpatient cardiology clinics.
Gotcha.
So, from Heather to my nurse, her name is Kim. We've invested a lot in our nurses within our practice in cardiology at UCSD, and really we've asked a lot of them too that they are the ones who handle prior authorizations, help ensure access to therapies for our patients. So that is a lot of work and education that goes into that training to have that expertise, and also just learning on the job. It takes time and experience, and understanding how this system works and how you can effectively get some of these therapies to patients. People sometimes just need to learn that through that experience.
Yeah, one of the things I love about working on a team is when you ask your team member to do something, you're saying to them, I trust you.
Yes.
You're going to help me take care of this patient.
Yeah.
You are taking care of this patient, and it gives them ownership and responsibility for this thing, and it adds to their life and job satisfaction.
Yeah.
So
Absolutely.
And what comes to mind is there's value in that. There's financial dollar value in that. And not everything gets translated to dollars, but there is value in that. And there's value to them because it's something that they can do that's really special to them.
Yep.
And it's an important part of the care. So I think it's really good to make sure that we enlist people and make sure they know that they're actually really providing a really important part of the care.
And on that note, I think one of the things that we highlight in the paper is the way that in some systems, mine included, nursing has also played a part in access to newer therapies. So lipid-lowering therapies that are administered in the clinic, for example, a subcutaneous therapy that has to be administered by a healthcare professional or an IV infusion. And so that is changing in clinical lipidology and cardiometabolic care. And whether it's the Heather, Kim, or nurse team that you have in your center, or it's a team led by pharmacists, we need more and more people with that level of expertise to help us roll out these programs that our patients need in order to access these newer novel therapies.
Drugs don't work if you can't get them.
That's right.
Right.
And the system doesn't work unless you have something set up to enable each cog to do what each cog needs to do.
Right.
And different systems may do it differently. Like I said, at our system, it's the pharmacist who's doing most of that, and we have like special infusion team for certain injections that have to be done at the clinic.
Yeah.
And so we're a little more piecemeal that way. It sounds like you're more integrated into your actual lipid clinic.
We are, but my takeaway point there is that no matter how you get there, you can get there with your team, and that'll look a little bit different wherever you are.
Yeah.
The members of the team will be a little bit different, but we can all get there.
Before we move away from the nursing member of the team, I wanted to bring up something that you didn't write about in your paper, and I just wonder if this was something that crossed your minds. Some of you may be familiar with the checklist manifesto. You've heard of that it's people in internal medicine don't really think in those terms really, but the surgeons do. They know that that the operation is not done until all the boxes have been checked.
Yeah.
And this helps prevent major errors that are completely avoidable. But there's relevance to the care that we provide. We have, we're learning about, lipid management and cardiometabolic management is a full system, holistic approach. And in order to do all the things we need to do and provide holistic care to our patients, we do need to actually start thinking about checklists. And in the operating room, it's usually the nurse is in charge of the checklist, is my understanding. Since your program, Mike, is so driven by that nurse director, or maybe I'm overstating that, but that it seems like the nurse director, does your nurse director have a checklist to make sure that all of the aspects of the care for each patient is being provided? And do you think that would be valuable?
Yeah, that's a great question. I'm not sure if we have a checklist per se that our nursing team uses, but I can give you an example. In our clinics, we administer inclisiran, and that was a program that we built essentially from the ground up, and our nursing leadership was huge in making that successful, and a lot of that had to do with the work that went into organizing everything and essentially creating checklists. In which, if you want to administer this therapy to your patients in clinic when they come in to see you, there's a way we can do that, but the work of putting that process together, developing the checklist or way that we would roll that out in the clinic was really up to our nursing leadership, and they did a phenomenal job. I mean, the program has been really successful. Patients have been very happy because they have experienced this very thoughtful, streamlined experience.
Yeah. So let's get back to the pharmacist.
Yay!
Yeah, I thought you'd enjoy that. There's this meta-analysis by Dave Dixon, one of your authors.
Yes.
And I'm told that when pharmacists are involved in the care of patients, my patients do better.
Yeah, life is so much better.
That is a blow to my ego, I have to tell you.
It doesn't mean that you're not doing great.
All right.
It should not be a blow to your ego.
When our powers combine,
Yes.
we create
That
Captain
is
Lipid.
the way to look at it. Yes.
All right. So tell me what Dave and his colleagues found when they did this meta-analysis. Just a brief overview. And we don't have to go into the details.
Yeah, so when Dave and his colleagues looked at all of these different articles that had pharmacists giving clinical care, so integrated into the clinic, seeing patients for monitoring, seeing patients for actual medication titration. So again, under a collaborative practice agreement, they showed significant reductions in all the key endpoints that you want to see: total cholesterol, triglycerides, LDL cholesterol, even A1C and blood pressure. And I think that again just goes back to when, number one, pharmacists are great at titrating, pharmacists are great at understanding how meds work together and how to make people successful on the meds that they're on. But it's bigger than that, because when you think about a patient who's coming to see a pharmacist, they want to ask me about their knee pain, but they don't. Or I tell them, I'm not your provider for that. And so it gives us dedicated time to talk about those things, which again, I think is that team-based care, finding the patient, finding the provider that can give that specialized care. The patient gets longer to talk about it, think about it, strategize on it, and that makes a difference. And we saw that. We've seen that time and time again.
And Dan, I think that one of the things I love about this paper is that if you read through it, you will find something like that in every section.
Yes.
And so if you look at the prescription of medical nutrition therapy by a registered dietitian nutritionist, there are benefits. There are benefits to all of the risk markers that we care about. If you look at data where APPs were involved in management, there's improved counseling, for example, around smoking cessation. If you get genetic counselors involved, there's an improved patient experience in understanding their test results. There's more cascade screening that happens. So you can just go down the list and see the value added.
Each team member adds an incremental value, makes the whole part better. That's brilliant.
Captain Lipid.
And I'm not Captain Lipid.
We come together and our powers combined create.
I'm with you. I'm on board. One last question about the clinical pharmacist. Does an interaction with a clinical pharmacist require a special visit to the clinical pharmacist, or are we talking about just a behind the scenes, working through the clinician primarily? How does that? What are the logistics of that?
In the meta-analyses and in those papers, it was a dedicated visit with a clinical pharmacist. I think that has value. I also think that in the age that we're in now, it can be telephonic, it can be virtual. So we at Grady have created an amazing medication adherence program, because we have these patients and they get their first fill, but they may not get the second, third, or fourth. And that is huge when you're talking about diabetes, hypertension, cholesterol. So it can be telephonic, but in a perfect world, it is an actual human clinical pharmacist that is going to not just help you pick the right med, but also, again, educate the patient on how to best use it. Let the patient ask all their questions. I swear, if I get asked once, I get asked a million times, but I like to have a drink on the weekends. And we can talk through that and we can let them get it all out. Whereas, in your provider visit, you're like, don't do that, or it's fine, or whatever the answer may be to whatever the question is. But we can really assuage that fear with them. So in best case, it's in person. It can also be telephonic, but I do think it needs to physically be that pharmacist interaction with the patient.
All right, I'm on board. I got it.
Happy to come to your clinic anytime, Dan.
We do have in clinic with us a registered dietitian who's superb. She's been working in our lipid clinic for longer than I've been in our lipid clinic. And she's available to meet with any and all of our patients, at anyone who's interested in. And I know that I give broad strokes. Michael, I think your acumen with regard to dietary intervention is much higher than mine, based upon conversations we've had. I know that to be the case. And I wonder, you're very sophisticated with regards to dietary intervention. Do you still utilize a dietitian in your clinic beyond what you provide?
Absolutely. Yeah. I mean, I wish that I had greater access to the support of a registered dietitian nutritionist. I don't have one in clinic. It does require a referral, getting patients set up with somebody outside of our clinic, but there is no way that I'm going to be able to match the personalization of dietary recommendations in the constraints, the time constraints that I have for a routine clinic visit. So I really value the additional expertise that a registered dietitian can bring.
I've noticed that even though insurance reimbursed visits with dietitians can be pretty limited, a lot of health systems and insurers now are setting up programs for weight management where they get assistance with dietitians, and patients are coming in and saying, hey, my health insurance provided a visit with the dietitian 4 times a year, and I think it's just a telephone call primarily. One of the things that our dietitian pointed out is even though she is with me in clinic, she actually likes the virtual visits because the patient can take their mobile phone into the kitchen.
Open the fridge.
Yeah, open the fridge and say, here's what I got.
Probably more scheduled.
And I think for that kind of, maybe
That's
face-to-face
awesome.
is better for certain things, but for that, boy, that is a really powerful visit. And you can see the Fruit Loops container up in the pantry, and you really get a chance to see into the kitchen, which is really important.
That's
so
awesome.
in addition to resources like community pharmacists, one of the things that we really emphasize in the paper is the use of registered dietitians outside of your healthcare setting, outside of your clinic, as well as genetic counselors. Telemedicine or telehealth, I think, really lends itself well to connecting with those members of the multidisciplinary team, and really should expand access for patients.
Right.
Yeah, we also, I actually am in the translational medicine and human genetics division. That's who pays my paycheck. But with regard to genetic counseling, I work closely with genetic counselor. We have one who's assigned to our program in particular. That doesn't mean that our GC is with us in clinic. What that means is I'm seeing Mr. Smith and I say, hey, I think you would really benefit from genetic testing for your lipid or other cardiometabolic disorder. I have a tool to do that, and I have a colleague who I work closely with who will help arrange that. And better than that, after you get the results, they will guide you through what the results mean and help you with your family counseling, because that's really probably the most value that we can provide is, and we don't just take care of the individual, we really are taking care of full families.
Right.
Primarily, I think we learn that with familial hypercholesterolemia, but it goes beyond FH. It's not just FH.
Absolutely.
And, so we work closely with GC. So tell me, Michael, what's your experience with that? Or, sorry, tell me, you look like you need to say something.
Sure. No, for genetic counseling, I agree with everything that you said. It's hugely important. It's a resource that I wish we had greater access to. There is a ton of demand and a lot asked of the genetic counselors that we do have in our system. And currently they're seeing patients with many different inherited disorders, inherited risk factors. So, not only lipid and cardiometabolic, but heart failure, other situations, pre-pregnancy counseling, et cetera. So it's tough, I think, to find genetic counselors who might be dedicated to lipid and cardiometabolic conditions, but that's a starting point. Starting to work with that person, or maybe it's a couple people you have in your system, and that's how I approached it. I reached out to her and I said, would you like to start seeing some more patients with familial hypercholesterolemia? Because we can work together on this, and I'm going to see the patients in clinic, then they're going to get counseling with you. We're going to, this is going to be us working as a team, and so we have gradually expanded the number of patients with FH that she sees, in addition to patients with all the other inherited conditions. The other thing I was going to say about dietitians and other members of the team that we're talking about is the importance of cardiac rehab. You had mentioned weight management programs, but having dietitians built into cardiac rehab is another huge resource that maybe not every health system has, but we need to be encouraging more of our patients to participate in cardiac rehab, and built into that is time with registered dietitians.
Yeah, I don't know if I want to call wearable devices a team member that's as part of this, but in a way we have to find all these different ways to engage our patients, and the exercise component is pretty challenging. And while it's not that easy to find an exercise physiologist to help train our patients, they can access their local gym, they can access a trainer, they can, if they qualify, access cardiac rehab. But you know, for many patients, it's really just an introduction. And so wearable devices can really be a good team member. Am I allowed to call it?
We did talk about
device?
that when we were going through the paper, and the data were not there for us to comment on it in the paper. But yes, we did have that discussion about, you know, wearable devices or other resources that patients do access. The data just aren't there for us.
Maybe that's the next iteration of this paper.
Yeah.
Okay, all right,
version 2.
So, you know, we talked earlier about the communication between team members, and I'm going to make a plug for what I consider a very important part of communication, which is the human interface of communication. The whole reason we communicate is to let another human know what we're thinking.
Yeah.
And we've all seen these notes that are sent from one person to another.
Yes.
In the same font, with no bold print, no italicizing, no highlighting the important aspect of what we want them to read, and burying our impression and our plan way at the bottom of a 6-page document that with lots of other things. So I am going to make I'm going to take advantage of this pulpit to say, if you're going to send a message to a colleague, put your impression and your plan and your question at the top of the page.
Yes.
If they want to read all the gory details,
I'm not doing it.
They can scroll down.
I'm not doing it.
Thank you.
Yes.
So you heard it first here.
I'm with you. I'm with you.
So please, and by the way, we're all on templates.
Yes.
This is the easiest thing to do. And that statement about, you know, this may not be, I don't know all the legality of where you're supposed to write, oh, I just had a televisit versus a live visit, all the disclaimers and everything. Seems to me that can be buried at the bottom. No one else needs to read that.
Right.
So put your disclaimers and all the other things in the document, of course, but put it where that person needs to see it, which is not really at the front.
I will say it throws me off a little bit because I'm so used to just scrolling all the way to the bottom, and I get to the bottom and I'm like, oh, it's at the top.
Wait, it was at the top. Yeah.
Thank you for putting it at the top,
Yes.
but I didn't
That's
even
4
pay
seconds
attention.
you'll never get back.
Exactly.
Great. So that's really important. And then one other aspect about being on a team, I just an anecdote. I was talking when my kids were applying to colleges and sort of planning out their world, and talking to a friend of mine who has a thriving business. He made this comment that when he's hiring young people, he actually asks what team sports they've played before, and that he had a personal preference for young people who had been on teams before.
Interesting.
He said on the kind of team, because his business operated like a team.
Yeah.
And he said if they were team sports participants or drama teams, it doesn't have to be sports, but team, if they had trained in teams, they knew that each member builds each other up.
Yes.
And sometimes one member is flying high and ignoring the rest of his team. And the nice thing about the team is they bring him back down to earth and they say, hey, we're all in this together. Let's work together. Yeah. And I thought those were really good words of wisdom. And, so I don't know if we need to highlight any other key aspects. Do you think there's anything we didn't go over?
Yeah, I'll just say we do go over barriers to this.
Okay.
So it is not easy to do. So even in my academic medical center, I don't have a genetic counselor, so I learned a lot from Emily in this process. But I think we need to understand as an organization, as a healthcare community, that this is not equitable for all of our patients. And where you go to see your provider means that you will have different resources, and that's not okay with me. We need to make sure that this is equitable. So we do talk about some of the barriers, be it provider status or adequate reimbursement. Like you mentioned, for dietitians, they can get reimbursement for diabetes and chronic kidney disease, but not necessarily cardiometabolic care. And so those things do need to be addressed, and we do talk about that at the end of the paper. Yes, we give you resources on how to engage these in the community, but understand that there is still a lot of work that needs to be done.
Absolutely. Yeah, this paper is also meant to be a call to action, because we are, highlighting all of the important things that every member of the team brings to the table enhances patient care in so many ways, but then if you can't get some of those services reimbursed, if you can't support those members of the team, then this is not going to be a model that we can build out in multiple health settings across the country. So we really need, the value is clear, and so we need that to be reflected in the way that we support and compensate members of this team.
That was fantastic. I really enjoyed this discussion with both of you.
Same.
For this episode of Lipid Insights at the MNLA Scientific Sessions, May 2025 in Miami. So if you heard the background noise, you were hearing everyone enjoying the meeting, and we're in this so-called soundproof booth. So this was a real pleasure. I love learning about team from both of you. Mary Katherine, thank you so much. Michael, thank you so much. Great work.
Thanks,
It was
Dan.
great to be here.